Welcome again to Works That Shape the World this evening. Our guest this evening is Elizabeth Roberts Pedersen. Let me begin, as we always do in the Humanities Research Centre, by acknowledging the first Australians on whose traditional lands we're meeting, and pay our respects to the Ngunnawal and Ngambri people, and acknowledge their elders past, present and emerging. Our guest speaker this evening is Dr. Elizabeth Roberts Pedersen, a senior lecturer at the University of Newcastle. And she has recently completed an ARC DECRA fellowship on the uses of psychiatry during the Second World War. The resulting book, Unquiet Minds, Soldiers, Civilians and Psychiatrists in the Second World War, is contracted to Cambridge University Press. But Elizabeth is also the author of a previous book, Freedom, Faction, Fame and Blood, British Soldiers of Conscience in Greece, Spain and Finland. Uva. So this evening, she'll be discussing a watershed moment in the history of psychiatry, the recognition of post-traumatic stress disorder in the third edition of the Diagnostic and Statistical Manual. If, like me, you're not quite sure what that means, but you think it sounds important, then Elizabeth will explain that to us this evening. Now, as you can see, we're in a webinar format. So we're going to ask you during the question and answer time to use the Q&A function down at the bottom of your screen to ask questions of Elizabeth. So please, we'll welcome Elizabeth. We'll ask you to share your screen. We found before there was a little bit of possible sort of video lag, but I won't let you know, and we will hope for the best.
All right. Hi, everyone. Can you hear me all right? There, Ibrahim, if you can just let me know. Just let me know if that's all right. Ibrahim, you can hear me, you can see the slideshow. Thank you. Yes, so connectivity issues. I was telling Ibrahim that I think because everyone is on Zoom in my street simultaneously, that the internet's been a bit patchy the last couple of days. So if I drop out, that's the reason. I'll have to do a recording or something. But thank you very much for that introduction. And thank you to the Humanities Research Centre at the ANU for putting on this series. And in particular, I want to thank Professor Will Christie for organising the program on medical humanities, which is clearly very timely. Three quick things before I get to the substance of the paper. First, I want to acknowledge that I'm speaking to you from Newcastle, which is a Wabikal land. Pay my respects to elders past and present. Second, I just want to briefly acknowledge the difficult circumstances that we're all living through. You can't see it, but off screen, I've had to make a barricade to keep my young kids from interrupting the talk. And so I know how difficult it is to attend events like this during lockdowns with all the various pressures that accrue. So thanks everyone for being here or for listening in, and all the very best to everyone during a difficult time. The third thing that I always like to stress, I guess, when talking about psychiatric diagnosis is that while I'm going to be speaking tonight about the process by which post-traumatic stress disorder, PTSD, became an official diagnosis in the American Psychiatric Association, the APA's Diagnostic and Statistical Manual, the DSM, it's a process, I suppose, about professional mores that I want to unpack. It's not my purpose to dispute patients' experience of that condition, nor the reality of anyone's suffering. What we really want to try and understand in work like this is the circumstances that allowed PTSD to become an official diagnosis and the consequences of that. So we're interested, if anything to do with, a patient's pain, it's about how that pain is interpreted, not disputing the existence of the pain itself. So tonight my talk is in three sections. First, I will cover the history of the DSM, and try and place it within the broader project of psychiatric classification, which has always been a vexed issue for the discipline. The second thing I'll do is talk about the emergence of post-traumatic stress disorder, how it came to be in the third edition of the DSM. As some of you all know, that's a process that's tied up with the Vietnam War, the difficult homecoming of some American veterans, and the work of some clinicians who are also anti-war advocates. And then in the last part of my talk, I'll discuss some of the consequences of PTSD becoming official. And I'll try and talk for about 40 to 45 minutes, given that everyone's got Zoom fatigue. I'll try and keep things brief. All right, so part one, the DSM, the impulse to describe, categorize, and otherwise organize psychiatric disorders and their symptoms. The practice of nosology, technical term, has long been of concern to clinicians who are treating patients suffering from psychiatric distress. And just a note to say here that I use the term clinicians because there's a bunch of terminology that goes along with the practitioners of psychiatry in the 19th and 20th century, alienists, neurologists in the 19th century, psychiatrists, psychotherapists, psychologists, psychoanalysts, etc. in the 20th century. Clinicians is just easier. So it's been a constant concern of clinicians, but classifying psychiatric disorders presents particular difficulties insofar as that there's no external objective measurement of psychiatric disorder or anything that really distinguishes one psychiatric diagnosis from another outside of the descriptive criteria that is agreed to by clinicians. So for the purposes of routine diagnosis, in the past, in the present day, clinicians consider a patient's symptoms and their behaviours as the key diagnostic indicators. There's no recourse to a blood test or to imaging studies, except to rule out certain physical conditions that might mimic psychiatric ones. And this means that more than other branches of medicine, there's always been a heightened degree of subjectivity in diagnosis, and one that's very hard to arbitrate by use of external technology. So classifying psychiatric disorders always been a thorny problem for the discipline, but it's also been considered something highly necessary for the discipline as it sought to achieve a kind of medical or scientific legitimacy. It's very difficult for practitioners to share and advance knowledge in the absence of common terminology and a common conceptual universe. It's also difficult to form knowledge about prognosis or therapeutics in the absence of a classificatory system. So for clinicians who are worried about the scientific legitimacy of psychiatry, that's most clinicians, particularly in the 19th century and probably up until the interwar period in the 20th century, sorting out classification as a means for diagnosis, reliable diagnosis, was a crucial task. And there was a practical element to this as well. There's clearly an administrative benefit that attaches to the project of classification. The administration of institutions in which the psychiatrically ill are brought together, so hospitals primarily, but also other kinds of therapeutic endeavours, is made much easier by a shared or a common understanding. Classifying patients aids in planning, or at least feels like it does. That is very important in the administration of these large institutions. And admission books and other forms of record keeping can only make sense by way of shared terminology. And that becomes increasingly important as psychiatry in the West evolves into a semi-custodial enterprise over the course of the 19th century. In these large and increasingly overcrowded institutions, some form of certainty for doctors and patients' families is important, even if the main question that these classification schemes are trying to answer is whether a patient will recover or not. So I've rehearsed all that to say that the DSM really comes out of a longer tradition of clinicians grappling with the problem of classification. And probably the most often cited example, and one that's very pertinent for the American case, is the work of the German psychiatrist Emil Kraepelin, who in the late 19th century authored a famous textbook that he constantly updated as he refined his own classification system that he based on the study of large numbers of patients moving through the asylum clinics of Heidelberg and Munich. Though they were constantly changing, his classification systems were empiricist in spirit, and they were also prognostic. That is, he was concerned with describing the onset, the progress, and the final outcome of psychiatric illnesses, which he regarded as discrete disease entities that were naturally occurring. He was not so concerned with the causes of these illnesses, and that separated him both from the brain pathologists who would sort of perform autopsies to try and understand the root of psychiatric distress, and the Freudians towards the end of the 19th century. And it was his intense skepticism towards the latter and what he regarded as their propensity to construct castles in the air that explains his appeal for the proponents of DSM-III, who felt that they were also repudiating the woolliness of psychoanalytic thinking that had infected the practice of American psychiatry since the end of the Second World War. Now, War is also important to this story, which I suppose, of course, I was going to say because I've been working on military psychiatry for the last few years. But wartime, and particularly, the two world wars, also presents acute administrative problems for clinicians who are working in the armed forces. And they learn certain lessons in wartime that they bring back to peacetime practice. During war, they're required to manage a really large number of cases very quickly. And they have to make diagnostic decisions that have a direct impact on operational matters, on repatriation decisions, and on pensions. So classification and a common system of classification matters. That had been very apparent on the Western Front during the First World War, for example, when the wide application of the term shell shock by British medical officers had created considerable confusion in terms of how patients ought to be treated and whether they should be evacuated or not. And High Command had had to come in and clamp down on the use of this term to try and abate what they perceived as a flood of men leaving the front lines. And clinicians in World War II, in the British and the American armies, the Australian Army too, faced similar dilemmas. The typical task of these clinicians was not diagnosing men with the very serious psychiatric illnesses that might have landed them in asylums in peacetime. Usually, the pre-selection processes had weeded those men out, though not always. But they did have to deal with large numbers of men suffering from reactive, or what was the parlance of the day, neurotic disorders that had developed in response to the wartime environment. And so even more than therapeutics, the question of what was to be written on the form, on the paperwork that inevitably accompanied an enlisted man as he was sent for treatment or reassigned to do less taxing work or discharged, that terminology came to matter very much. And for that reason, during World War II, both the Army and the Navy developed their own classification systems in order to manage the paperwork. And it was the Army scheme, which had been overseen by William Menninger, who was the head of Army Psychiatry in the United States, and was later head of the APA. You can see this wonderful image that appeared on the cover of Time magazine in October 1948 with the key to the brain. He developed a classification scheme that was then picked up by the Veterans Administration after the war, which by its own estimation was facing a crisis of neuropsychiatric cases that threatened to overwhelm its infrastructure. So the war taught lessons about the way that having a kind of administrative framework underpinned by a common system of diagnosis was extremely important. So there were these wartime tendencies that were fueling, I guess, the classificatory bent of post-war American psychiatry, and international developments in health governance were also moving in a similar direction. After the Second World War, global health governance mechanisms through the WHO began to include mental health within their remit. So the sixth edition of the International Classification of Diseases, the ICD acronym, which was published in 1948, for the first time included a section on mental disorders, again informed by the wartime experience. And the first edition of the DSM, which was published in 1952, drew on both the VA classification system that had emerged from the Army classification system, but it also looked to the ICD-6 for, I guess, a guide about how to categorise disorders. Now, you possibly can't tell from the image that I've used here, but the DSM-1 was a very slim, almost like a working document. It was less than 150 pages. It was spiral bound. And it was based on the notion that mental illness was a reaction to circumstances and environment. So very much a legacy of that wartime context. The second edition was published in 1968. And while it moved away from the categorization of mental disorders as reactive, sort of started to eschew that terminology, it retained and even doubled down on the psychoanalytic concepts that had been evident in the first edition. And that meant that there was not much emphasis, or any emphasis, on objective criteria or symptoms as an aid for clinicians wanting to diagnose people. There was quite a lot about particularly neurotic mechanisms and the way that generated certain kinds of unrest. But the process of diagnosis very much rested on the expertise and judgment of the treating clinician. Now, I've said that DSM DSM-II is published in 1968, and this sort of reification of the clinician as all-knowing didn't fit well with certain trends in the culture. There is discontent brewing in American society in general, but it's also happening within the psychiatric profession and within the APA as a body. And they're being attacked, I guess, from a couple of quarters. On the one hand, there are self-styled radicals who attack the APA, both from without and within, as a kind of bastion of conservatism that's upholding the status quo. Coming out of the counterculture, it's also influenced this sort of radical critique a little bit by the writings of the anti-psychiatry movement, though they don't agree with all of its precepts. But the point, yes, was to attack the APA for defending the status quo under the guise of a kind of doctrinal purity. Now, the most famous outcome of this radical critique was the success of the gay liberation movement in having homosexuality removed as a disorder from the 1974 printing of DSM-II. But it's not just the gay liberation movement that's part of this critique. There's also pressure from the feminist movement, from female clinicians, and also from Black clinicians. Lots of pressure to try and get the APA to recognise that it was not just personality that caused, or sort of idiosyncrasies of personality that caused psychiatric distress, but that external circumstances could do that as well. So things like racial injustice, gender discrimination, socioeconomic factors could cause mental distress. Now, at the same time, but from a quite different premise, and there's not much crossover in these two groups, there are other clinicians who would also become frustrated with what they regarded as the discipline's lack of scientific rigour. You know, it's kind of a perennial concern up to this point. There's a series of scandals that we don't really have time to go into, where you know, researchers had gone out of their way to try and prove that diagnosis was chaotic, that the same patient could present to three different clinicians and get three completely different diagnoses. They're also worried that there was insufficient attention being paid to the biological basis of mental illness, something that was becoming increasingly accepted as psychopharmaceuticals began to, you know, be prescribed in greater numbers and were seen to be demonstrating their efficacy. There was also a question, I suppose, about the capacity of researchers in psychiatry to attract federal funding, which was distributed on a kind of medical model. And so an emphasis on data, on quantitative data, was becoming very important. So when the DSM-III task force was convened in 1974, and so I should say that the writing of these manuals, it's a years-long consultative process. So the work begins in 1974. Its membership reflected not the radical psychiatrists or the radical clinicians attacking the APA, but this latter group of clinicians who were frustrated by what they saw as the lack of rigour in the diagnostic schemas that were being endorsed by the APA. And I think the makeup of the task force is evident that there was a generational change afoot, that the post-war generation, Menninger and co, were no longer in charge of setting the course of the discipline. The head of the task force was a man named Robert Spitz. Now, he kind of embodies, I guess, this generational shift. He had been trained in psychoanalysis, as most psychiatrists were. They trained in the late 40s and the 50s, but he'd become disillusioned. And at the time of his appointment as the head of the DSM-III task force, he was attached to the New York State Psychiatric Institute, where one major tranche of work that he and colleagues were doing involved developing diagnostic criteria for evaluating incoming patients. In a sense then, DSM-III sought to do this for the psychiatric field as a whole. So that practice that Spitz was doing in his private work, in a sense, he brought that to the work of the task force. The point was to produce diagnoses that were based on empirical observation and close description, and that were in theory reproducible by clinicians working across various locations. And so for that reason, the DSM-III came to include the kind of diagnostic checklist that Spitz and colleagues had used in their intake work at the New York State Psychiatric Institute, and that are still used in diagnosis and evaluation today. Now you can see, I guess, from the worldview that Spitz brings to this task, why he and some of the people involved in the work describe themselves as neo-Kraepelians. Now, whether Kraepelian would have agreed with that connection is another question, but at least in approach you see the similarities, particularly in the use of an aggregate of intake data to inform diagnostic categories. You can also imagine the way that this, a more quantitative approach meshed nicely with federal funding regimes, also with the use of medication. If you standardise diagnosis, you could theoretically standardise treatment modalities and include medication and dosage, that kind of schema. This is very different from psychoanalysis, which reified the case study as the driver of disciplinary knowledge, relied on unobservable unconscious conflict as the progenitor of psychiatric distress, and which, at least in theory, mandated long-term talking therapies as treatment. And I say at least in theory because I feel like I have to point out a lot of psychoanalysts are also using medication by this point, using them in tandem with talking therapy. So there's not a hard binary there necessarily. All right, so though it sounds traumatic to say it out loud, for historians of psychiatry, it's not an exaggeration to say that the publication of DSM-III in 1980 was a kind of banishment of psychoanalysis from the clinical mainstream of American psychiatry, at least in terms of clinical practice. It probably didn't feel like that culturally, and the picture is a little confused because I think psychoanalysis has a kind of second life in the academy, in humanities departments. But for the biologically attuned clinicians, the young Turks of the 1970s, that only confirmed that the analysts had always dealt in fairy tales. All right, so where does PTSD fit into this story? Here again, there is a wartime context. From the late 1960s, clinicians involved with the anti-Vietnam War movement, like Robert J. Lifton, the famous clinician, and Hyam Chaipan, they had begun to use the figure of the mentally troubled Vietnam veteran to argue that America's involvement in the conflict was immoral and, possibly more importantly, for trying to bring public sympathy to their cause, that it was damaging to the young American men who were doing the fighting. The famous article in the New York Times in May 1972, where Chaipan uses the term for the first time, post-Vietnam syndrome, to refer to the pattern of symptoms experienced by these returned soldiers that included things like guilt, rage, and feelings of victimization. Now, what's interesting about the descriptions in the clinical literature of this syndrome, and remember that some of these are coming from, staunchly anti-war clinicians who are also involved with anti-war veterans groups, such as the Vietnam Veterans Against the War, the VVAW, is that alongside the things that you see in the clinical literature of the two world wars in bringing about psychiatric distress, fear of death in conflict with, the want to do duty, not to show fear, guilt over the death of a friend, there's another element, and that is guilt over the violence done to Vietnamese civilians. And that means that for anti-war clinicians like Lifton and Chaipan, that the fact that the patient is a perpetrator comes to serve a really important function. The fact that the patient is a perpetrator makes them a special kind of victim, and they become very important in anti-war advocacy. That attitude unsettled some observers who felt that overly solicitous therapists were offering veterans absolution for war crimes. But for Lifton, who is a great synthesizer, bestowing veterans with the double status of perpetrator victim allowed him to position them within a diagnostic lineage as traumatized survivors. Throughout the 1950s and the 1960s, there'd been a growing literature on the suffering of Holocaust survivors, and that had emphasised the persistence of victims' guilt feelings, due in part to what clinicians claimed was an unconscious and defensive identification with their persecutors. You can see there's a Freudian residue here. But for Vietnam veterans, theorised Lifton, this identification, while no less anguished, was actual rather than symbolic. It was grounded in the veteran's dual identity as a perpetrator victim, and it manifested in the bursts of anger and ruminative guilt that characterized post-Vietnam syndrome. From that vantage point, the ordinary American boys who razed Vietnam villages and shot inhabitants were themselves suffering from a psychic wound. As one veteran seeking admission to a VA hospital put it, "I have lost the sanctity of life." Now, in addition to making the overall morality of the Vietnam War a clinical matter, post-Vietnam syndrome also rejected an exclusively interior model of psychic conflict. And that's crucial for understanding why PTSD comes to be in the DSM-III. Clinicians treating veterans with post-Vietnam syndrome insisted on the primacy of actual events in evaluating psychiatric distress. Like the suffering of Holocaust survivors, veterans' pain, they said, was caused by things that had actually happened in the world. There was nothing sort of symbolic or imagined about it. And you can see the way, despite, as I say, the kind of Freudian residue in some of the language, that this was amenable to the worldview of the framers of the DSM-III, because the syndrome at least had some tangible qualities, an animating circumstance, and what Lifton and Shaitan and their colleagues claimed was a characteristic set of symptoms. So why does the DSM-III have an entry for post-traumatic stress disorder and not post-Vietnam syndrome? Well, despite the anti-war clinicians' repudiation of Freudian precepts in terms of the mechanism for producing psychiatric distress, a disorder that applied only to Vietnam veterans was obviously, too niche for a diagnostic schema that aspired to be universal, or at least encompassing. But it was also too political, too obviously anti-war. And the APA had struggled very much from the late 1960s into the mid-70s about how to respond to the Vietnam War. Critics on the left accused it of being, too neutral, not political enough. They should get involved and declare the Vietnam War a sort of psychiatric emergency. Critics on the right saw that as being, too political and not befitting a medical or professional organisation. So there were those kinds of pressures, not to endorse something that was such a political category. Also, there was just concern, particularly from Robert Spitz, but some of his colleagues, that veteran symptoms were adequately explained by existing anxiety and substance abuse syndrome. So that question of substance abuse sort of is rumbling in the background here. Initially the DSM-III task force thinks, look, we don't need another discrete disorder. We can fit the Vietnam veterans into existing categories. But Shaitan and Lifton were, in addition to being sort of good and eloquent clinicians, are very skillful advocates behind the scenes. So they come back to Spitzer with a proposal for what was now named, they said, post-combat disorder. And they elicited an agreement that if they could produce enough data to demonstrate the reality of that disorder, then the DSM task force would consider including it. From that point on, they seem to have understood that the price of inclusion would be not just dropping the reference both to the Vietnam War, but to war in general, and that they'd need to bring in and marshal the support of clinicians who were working with other kinds of traumatized patients to demonstrate that exposure to certain kinds of traumatic experience or a certain level of traumatic experience produced common behaviours and symptoms. And the working group that they convened was chaired by a clinician who worked with burns patients. And in the course of their discussions, she came to sort of see the similarities between the situations that, the symptoms experienced by her burns patients, who would often be in accidents, and the kinds of behaviours that the Vietnam veterans were demonstrating. Now, the fact that the anti-war clinicians like Shaitan and Lifton were able to do this, to get a kind of consensus and convince the DSM-III task force to include what they came to call post-traumatic stress disorder, the fact that they were able to do this suggests two things. Now, the first, and this is a very sort of almost cynical historian's take, is that public sympathy for the Vietnam veterans swayed the DSM-III task force. That they understood that public sentiment and the degree of sort of public advocacy work that Lifton and Shaitan had been doing meant that to sort of dismiss their claims for a new disorder would be bad publicity. That's cynical, but it may not be completely wrong. The other possibility, though, is that the framing of this disorder did capture something real and something that had troubled clinicians over the 20th century, particularly in a wartime context. That post-traumatic stress disorder came to speak to the conviction of many clinicians that there are certain dreadful events that would cause almost anybody to experience ongoing psychiatric problems, and that the problem in these cases was not with the patient's personality, as the Freudians would have it, but with the objectively terrifying and distressing nature of the catastrophic event. When you read the clinical literature of both world wars, it's clear, I think, that for many clinicians who were dealing with soldiers who had been through some horrendous experiences and eventually would break down, often they felt, very constrained by a conceptual universe in which individual predisposition counted for more than actual experiences. And they wanted to give more weight to these terrifying experiences that people had gone through, rather than still attach a kind of stigma to the patients who broke down. And PTSD does that. It reverses the diagnostic burden of proof. It relieves the patient, but it also, I think, crucially, it relieves clinicians of the need to argue for legitimacy or recognition for the patients who have been through dreadful experiences. The process becomes much more straightforward because the existence of the disorder can now be proved with reference to set criteria. So if we look at the diagnostic criteria that are set out in DSM-III, it's pretty simple, and the language is quite clear, and it's schematic, and it's a case of tick, tick, tick. So there are four conditions. So first is that the individual has to have experienced what the text describes as a recognisable stressor that would evoke significant symptoms of distress in almost anyone. The traumatic event, this is the second criteria, is re-experienced either as painful recollections, recurring dreams, sudden acting or feeling as if the traumatic event were reoccurring. That's the flashback. Due to stimulus or association. The third criteria is a sense of numbing or withdrawal from the world. And the fourth criteria is at least 2 new symptoms. And this is where it's kind of a catch-all. And you can see that the framers are trying to sort of, give as many people a chance to fall within this category rather than outside it. Hyperalertness, sleep disturbances, guilt, memory and concentration problems, avoidance of activities likely to arouse recollection, and so on. Now, these heads of diagnosis have shifted around. Avoidance behaviour has taken a more prominent role. But you can see that the architecture of the disorder is fairly well set in DSM-III by 1980, and that the key thing, is this reversal of the diagnostic burden of proof, in which it's a terrifying event that is the most important, rather than the predispositions that the patient has. So what were the consequences of PTSD becoming official in DSM-III in 1980? Well, for veterans who were suffering from the long-term effects of traumatic events, PTSD did give them a legitimating diagnosis. Now, I want to be careful here because although I've talked about the way that, ostensibly it removes some of the stigma of previous diagnostic categories, which talked about, unconscious conflicts and certain kinds of predispositions that traumatized people had, I don't know that it's necessarily experienced as stigma-less for people who are seeking treatment for PTSD. So I just want to be clear about that. But at least in theory, it relieves some of that burden. And that was in keeping with the DSM-III's embrace of an empirically derived rather than abstractly theorized classification model. It did, in theory, remove some of the stigma of the highly subjective and the psychoanalytically informed diagnostic schemas that regarded a patient's defective personality as the main driver of psychiatric illness. Now, this had really important practical effects as well. And, this is, what Liston and Shaitan were thinking about and what the, veterans groups were very interested in. Insofar as the diagnosis then entitled veterans to subsidise medical care via the Veterans administration. And this especially became the case after the VA, within about 18 to 24 months after the publication of DSM-III, had conceded that symptoms of PTSD could emerge long after the precipitating event, that they could be delayed. And that had huge financial implications for the VA, which is essentially a form of socialized medicine. It was really saying, anyone that's experiencing unsettling symptoms, we don't need to prove, a really tight sort of temporal link. It can be delayed, and these people come forward for treatment and receive subsidized treatment. So it has really important practical effects. But there are also effects beyond the cohort of Vietnam veterans. Critics have pointed out, rightly, the way that PTSD has tended to centre the traumatised male combatant or first responder, as the archetypical patient. I think that's true, and there's certainly an argument to be made that there's something about the male combatant that makes certain psychiatric syndromes in the 20th century suddenly sort of legitimate and able to be seen. I think there's something about male clinicians seeing other men in psychic distress, particularly on the battlefield, that legitimates certain conditions. But despite all that, it has also given other groups of people or patients a language and a framework through which to express their pain and suffering. I think it's been particularly significant for making visible the consequences of sexual violence and domestic and family violence. And certainly in the case of sexual violence, there's some really interesting ways in which feminists use the kind of survivor language associated with the Holocaust survivor syndromes of the 50s and 60s, and also the post-Vietnam War stuff to speak about rape survivors in a similar register. Now, of course, who we designate as traumatized deserving of compensation, traumatized and deserving of compensation is a political question. And I think it would be wrong for me to suggest that the mere existence of PTSD has dealt with that issue, but it certainly creates a kind of language through which people can advance their case. I think it also explains, and people like scholars like Ruth Lays and other people who work on trauma studies or try and critique trauma studies, think that it's linked to the expansion of trauma, or the concept of trauma beyond the clinic, and in its move into popular parlance as a synonym for lingering pain, suffering, or unease. It's a little reminiscent of something that Jay Winter, the historian of the First World War, has argued about shell shock. Shell shock dies as a diagnosis, as an official diagnosis, in early 1917. But it moves into metaphor, and it remains there, a metaphor for the suffering of wartime. And you could argue that there's a similar transposition with the idea of trauma. It kind of moves out of the clinic and its attachment to PTSD to mean something broader. As Didier Fassin and Richard Retzman argue in a very influential book called The Empire of Trauma, trauma has become more a feature of the moral landscape, serving to identify legitimate victims, then it is a diagnostic category, which at most reinforces that legitimacy. And that's linked to arguments that Fassin and Retzman, and particularly with Lays, have made that, has the category become too wide? Are we including too many people as traumatized? Is it losing some of its moral weight? So that's one critique of PTSD. I think it would also be wrong to suggest that there was not a cost to subsuming post-Vietnam syndrome and other survivor syndromes into PTSD for all the sort of administrative benefits that it accorded to Vietnam veterans. I think there was something lost in that, losing the specificity of those disorders. As its critics have noted, PTSD, it's not only neutral when it comes to the role of patients' personalities in fostering psychiatric symptoms, but again, it's pretty, inclusive, commodious, if that's the right word, in how it understands the effects of trauma, or how it, ascribes or measures the weight of traumatic effects. Once a certain threshold of seriousness is reached, this idea of a traumatic event that would have, meaning consequences for almost anybody. Its diagnostic criteria is satisfied equally by a Holocaust survivor, by the victim of a serious car accident, the target of an armed robbery, and ultimately, speaking to the Vietnam War case, by a villager whose family was massacred in a pacification raid and the GIs who did the killing. And it's on this basis that critics of PTSD argue that to some extent that it has become amoralized, or it decontextualizes trauma, and that it diverts scrutiny from the specific character of the violence that underlies patients' symptoms. And the argument goes that in doing so, it reduces the possibilities for incorporating socio-political commentary into clinical work. Therapy no longer for PTSD didn't really require a moral accounting, however circumscribed that was in the case of post-Vietnam syndrome, but there was, an implicit critique of the war embedded in it. So there's no moral accounting. There's not necessarily an examination of the institutions and the actions that make the violence possible. The point, I guess, of the clinical work is to erase the patient's symptoms, which are laid out on the checklist. And increasingly, in the 1980s into the 1990s, that's done with medication, remembering that the DSM-III is also very important in making prescribing medication, schematic in the same way that diagnosis is. Now, over time, the treatments for PTSD and the condition itself, I don't think it's an exaggeration to say that they are written into military budgets. They almost become an operational expenditure. And in that way, this is very different from post-Vietnam syndrome, that PTSD becomes a cost of war. No, it's no longer a critique of a military enterprise. Now, that decontextualization explains, I think, the rising interest in the last 10 years or so in military medicine, military psychiatry, and allied disciplines of a concept like moral injury, which positions certain elements of post-traumatic stress disorder symptomatology as a response to a moral crisis, in terms that are really reminiscent of the way that post-Vietnam syndrome was understood. And, this is coming out of mainly the American military, and it's clear that the links to the war, the trajectory of the war in the wars in Iraq and Afghanistan is very much linked to this, the moral crisis that is at the heart of moral injury. So that decontextualization is linked to a rise in a kind of adjacent syndrome that seeks to do that moral work. It also explains as well the critiques coming out of some fields of PTSD and the DSM itself as part of a kind of neo-imperialist project, trying to force Western disease categories onto other cultures. And Fassine and Rechtman, who I quoted from earlier in their book, The Empire of Trauma, they talk about the way that, humanitarian work and aid agencies often carry post-traumatic stress disorder and its architecture and its assumptions into other parts of the world, and sort of, treat the population in the wake of a natural disaster in those terms. Some of the sting may have gone out of that charge lately, given there seems to be a move to adopt the ICD in preference to the DSM. I'm not saying that the ICD is not sort of colonial in effect, but it's not as tied, I guess, to a national identity as the DSM is. Now, just thinking about the time, I want to conclude by speculating really briefly on the ways that the terms of debate about PTSD, but I guess also implicitly about the DSM, might change or be changing already. And I'm going to say this as from my vantage point as a historian observing the discipline, not as someone that sort of works directly in the clinical fields. But we've seen how the DSM-III was predicated on classifications that were based on observable symptoms rather than causes or origins. And the way that harks back to the 19th century, where Keelan was not interested in causes. He didn't see them as helpful for diagnosis. It was what could be observed. There was a sort of empiricist sentiment. But I wonder, and again, from outside the discipline, I wonder if the rising tide of neuroscience is not going to resurrect the question of causes or origins in a way that will make it difficult for diagnostic schemes to resist. And I guess I'm thinking here about questions about genetic predispositions to certain kinds of psychiatric disorders. And without commenting on, you know, how convincing those arguments are and what you can and can't tell from studies of genes and brain imaging, the fact that those questions are being asked and research is being done, I think could change people's perception of what diagnosis sets out to do. It would certainly be a boon, I think, particularly for military, the American military, looking at, you know, things like the pensions bill. If there was a way of screening soldiers genetically before they enlisted, or at least finding people who were predisposed to PTSD, that would be kind of ironic in a way, to be recursion to some elements of the Freudian worldview, which was very interested in individual predisposition. But I think we see some evidence of this. I mean, I've had to think in terms of doing some work on the Second World War and trauma a lot about the concept of intergenerational trauma, which, you know, there are important studies done in the wake of the war to theorise this. But in the post-war period, it was understood as a psychosocial process. It was something to do, you became traumatised, you know, the next generation became traumatised by living in close proximity to parents who had been through dreadful experiences and created a certain kind of emotional atmosphere in households. But that now is being, you know, reformulated as an epigenetic proposition. So it's not necessarily just the psychosocial environment. It's theorised that there are changes in the genes caused by traumatic experiences. It means the next generation is born with predispositions to certain stress responses. And so intergenerational trauma does not hold the same meaning that it does in the post-war period. It's understood in a very different, as I say, epigenetic form. Now, that's just one example. But if so, I would expect efforts to incorporate these kind of understandings into existing classification schemes, changing the way that psychiatric disorders are categorised and treated, and understanding the history of these efforts to classify psychiatric disorder and the consequences of those classification schemes, I guess both at the level of theory, but also in terms of practice and access to medical care, should keep us alert to those potential changes. And I think I'm going to leave it there.